Hi everyone, in this video we are going to talk about pathogenesis and pathological sequelae of tracheo-esophageal fistula and esophageal atresia. In previous class we have learned that tracheo-esophageal fistula is an abnormal connection between trachea and esophagus, and esophageal atresia. Normally, atresia is absence of normal passage. In this condition, upper and lower segments of esophagus doesn't connect to each other and remains blindly, so that this congenital anomalies will occur. And in previous class, we have studied that the main cause of this both the congenital anomalies is abnormal development of tracheo-esophageal septum. We already knew that gastrointestinal tract is made up of three segments called foregut, midgut and hindgut. Here is the picture of fetal gastrointestinal tract representing three segments of gastrointestinal tract. This blue portion is showing foregut, red color portion is midgut and green color image is showing hindgut. Knowledge of embryology is essential to understand pathogenesis of these abnormal congenital conditions. Let us see how trachea and esophagus develop in fetus. At 4th week of gestation, respiratory diverticulum develops as an outpouching from the ventral portion of primitive foregut. It means respiratory diverticulum, which develops as future respiratory tract, and esophagus. Both are the derivatives of primitive foregut. This is the cross section of primitive foregut. This portion is respiratory diverticulum, which evolves into trachea, and this portion is foregut, which develops into esophagus. Here we can see an opening between respiratory diverticulum and foregut. This opening is quite natural in the early stages of development. Later on, we need a septum to separate this respiratory diverticulum from primitive foregut. So, as a part of septal formation, tracheo-esophageal foldings develop on each side at the junction of respiratory diverticulum and foregut. These foldings will deepen in later stages and fuse in the midline in order to form a septum called tracheo-esophageal septum. So, this septum divides this respiratory diverticulum from foregut. So, this front portion means ventral part of foregut develops into trachea, and this dorsal portion of foregut develops into esophagus. Any defect in the formation of tracheo-esophageal septum leads to two defects. Those are deviated septum and incomplete septum. Coming to the deviated septum, especially posteriorly deviated septum leads to incomplete separation of esophagus from trachea, which ultimately results in esophageal atresia with tracheo-esophageal fistula. And incomplete septum. So, it occurs due to incomplete fusion of tracheo-esophageal folds, which results in abnormal connection between trachea and esophagus, which is known as tracheo-esophageal fistula. In very few cases, esophageal atresia occurs as an isolated congenital anomaly. It is due to failure of recanalization of esophagus during fetal stage. Initially, esophagus is solid tube due to accumulation of endodermal cells. Later on, disintegration of the cells takes place. It is under the process of recanalization, which converts this solid tube into hollow tube. If there is any failure in the recanalization process, will lead to this abnormal condition, that is esophageal atresia. Let us talk about pathological sequelae of these abnormal conditions. Normally, trachea connects to lungs and esophagus connects to stomach. But in esophageal atresia, esophagus doesn't connect to stomach. So, food can't reach the stomach and the food will be accumulated here in the upper segment of esophagus, which leads to aspiration of feedings into the lungs. Ultimately, aspiration pneumonia will also occur in this condition. In case of tracheoesophageal fistula, esophagus and trachea is connected to each other. So, food can enter into trachea and air can enter into stomach, which leads to abdominal distension here and here aspiration pneumonia. In case of combination conditions like esophageal atresia and tracheoesophageal fistula, esophageal upper segment doesn't attach to the lower segment, means doesn't attach to the stomach. So, food will be accumulated in the upper segment, can't reach the stomach. But air can enter through the fistula into the stomach, which leads to abdominal distension. So like this, pathological sequelae will take place in esophageal atresia, tracheoesophageal fistula and esophageal atresia with tracheoesophageal fistula, means combination conditions. Let's talk about clinical features. Clinical features appear soon after birth. It is characterized by 3 C's. Those are coughing, choking and cyanosis. On very first feeding, after first or second swallow, the baby coughs, chokes and the fluid returns out through mouth and nose. Immediately the child will face the difficulty in breathing, which leads to cyanosis. So in this condition, the baby will be exhibiting the excessive salivation, which leads to drooling of saliva and choking, regurgitation, gagging reflex, as well as abdominal distension due to accumulation of swallowed air whenever the baby is crying here. These are the clinical manifestations. This condition is diagnosed during antenatal stage itself with the help of ultrasonography. Ultrasonography reveals polyhydramnios, means excessive amniotic fluid. In this condition, due to atresia, the baby is unable to swallow the excessive amniotic fluid, so that the fluid will be accumulated in the proximal segment of the esophagus. So there will be dilation of the proximal esophagus and collapsed stomach will be noticed in this ultrasonography. And this condition will be confirmed with the help of fetal MRI. And this condition is diagnosed postnatally with the help of NG tube insertion. Whenever health professionals try to insert NG tube, then automatically they will face the resistance due to blind end of the upper esophageal segment. And then one more study, that is X-ray of abdomen and trachea. It is mandatory to classify the type of atresia and fistula. In type 1 and type 2 esophageal atresia, X-ray will be showing the dilated proximal end of the esophagus and gasless abdomen will be noticed. And in case of type 3, 4, 5, there will be large gas bubble in the abdomen. And one more condition also will be used to identify this condition, that is bronchoscopy. It will be used in case of fistula in order to visualize the condition of the fistula. Apart from this all diagnostic findings, sometimes the doctors will be recommended to go for echocardiogram in order to find out any other associated problems of cardiac system. And this condition will be treated surgically. That surgery also based on particular criteria, that is weight of the baby, distance between the upper and lower segment of the esophagus and breathing ability of the baby. And then usually it will be based on stages wise. If the distance between the proximal segment and lower segment of the esophagus is less than 2.5 centimeters, and if the baby is having the weight of 2 kgs and the baby is not having any pneumonia and then the baby is taking breath properly, in that case single stage of surgery will be done, that is end-to-end anastomosis and reconstruction, rejoining of the upper and lower segment of the esophagus, as well as division of the fistula will be done. At the same time, whenever the baby is having more problem during breathing and sometimes the baby is having pneumonia, as well as the distance between the upper segment and lower segment of the esophagus, in case of atresia, the distance is more than 2.5 centimeters and the baby weight is less than 2 kgs. At that time, this surgery will be done in two stages. In first stage, there will be division of the fistula and then gastrostomy is done to decompress the stomach, and in second stage, end-to-end anastomosis of the proximal and distal segments of the esophagus will be done. If the distance is more, then a portion of the colon will be used for the reconstruction of this area. This two-stage surgery will be done whenever the baby has reached 18 months of age. So that is the best age to conduct this complicated surgery in two stages. So this is how we will treat the condition. In this segment, we have covered pathogenesis, pathological sequelae, clinical manifestations, diagnosis and treatment of this condition. Thank you so much.